Okay, so hello again. You know who this is, and we were together way back in the spring and talked about a lot of these issues that we're going to talk about today. So most of this, probably a good 65 to 70%, is going to be review. And so if you need more thorough review rather than what I'm going to do today is basically quick summaries of important things that we talked about previously. But if you want to go back for more detail, you need to go back to the integrities from the cardiovascular and pulmonary rehab course that we did together in the spring. So we want to talk about ventilatory and cardiovascular dysfunction after spinal cord injury. We'll start with the ventilatory system, and as you can see in your handout, the leading cause of death after spinal cord injury is pneumonia, and the reason for that is secretions tend to accumulate in the lung, and so you have ways of eliminating those secretions. The reason for the accumulation of the secretions is muscle weakness, paralysis, inability to cough, and so things such as postural drainage, percussion, vibration might be necessary in somebody with a chronic spinal cord injury. You probably won't do any of those kinds of things in the acute situation because acutely the patient is being monitored closely so that whatever vertebral fracture took place, that fracture has time to heal. And so intensive kinds of things like percussion are probably are contraindicated. Certainly, some postural drainage positions would be indicated, and gentle vibration would be indicated. Breathing exercises would be a definite must. And so let's talk about the ability of the person with a spinal cord injury to inhale. We've got inspiratory muscles and the diaphragm. Its innervation is C3 through 5. C3, 4, 5 keeps the diaphragm alive. Unfortunately, you're going to have patients with real high cervical injuries. An example is Christopher Reeve, who was on a ventilator for his entire life after his spinal cord injury. He was a C2. And so anybody with that might have issues with their diaphragm innervation is probably going to need to be on a mechanical ventilator of some sort or another. There are also accessory muscles of inspiration, the scalenes, C3 through 8, sternocleidomastoid, C1 through 3, the pecs. If we can get the upper extremity stabilized, we can utilize pecs and pectoralis major, pectoralis minor, C5 through 7, serratus anterior, C5 through 7, and then the intercostals. Those are all segmental, so T1 through T11. But again, you're going to have to think about what level of injury that person has and whether they're going to have these accessory muscles or not. This is something you should be well familiar with. Structures that we've talked about previously, just a reminder of some anatomy. So again, level of innervation for the diaphragm, the primary muscle of innervation, and then the accessory muscles. Exhalation at rest. Exhalation is what? Exhalation is passive at rest. It's just a recoil of the lungs and the thorax. But then if we want to do a forced exhalation, such as a cough, to clear secretions, we've got to have abdominals. And the level of innervation for the abdominals, I'm going to spoon feed it to you, but you really should go back and review your anatomy. But it's T7 through T11. Again, a segmental innervation. T12, the subcostal nerve. L1, iliohypogastric and ilioinguinal nerves. And so those would all be innervating the abdominal muscles during a cough or a forced exhalation of some sort or another. This is out of your text from back in the spring, and again, we've got muscles of inspiration and expiration. And with inspiration, your text is saying that it's exclusively, as far as intercostal muscles goes, exclusively external intercostals, but there are those other folks that do elaborate EMG studies that would argue that the internal intercostals are also involved in inspiration. The scalenes again, sternocleidomastoid, and then the diaphragm. And not shown here are those other accessory muscles, the pecs and serratus anterior. So again, think about those levels of innervation, where they come off of the spinal cord. And again, you're going to need clinically to coordinate that with the person's level of injury. The bucket handle, pump handle things you're all familiar with, and we don't need to spend a whole lot of time talking about that. And then, similar to inspiration, your text is saying that it's exclusively the internal intercostals for expiration. And again, those that are out there that will argue that it's also the external intercostals that are involved in terms of expiration. And then you have abdominals that are called upon when we need this forced exhalation. We need to rapidly push air out of the lungs to eliminate any secretions and prevent the chance of getting pneumonias. We talked previously about static and dynamic volumes and capacities, and so you had a figure that looked identical to this. I've taken out some of the other things that related to obstructive diseases. Spinal cord injury is pretty much considered to be a restrictive disease because of, again, the muscle paralysis and the weakness. So here you have the tidal volume. Here you have the vital capacity. And there's other volumes, and there's a residual volume that we can't get any air out no matter how hard we try. And then focusing on the slope, and this is a normal individual now, okay, on the left. If we put somebody with paraplegia, and I'm trying to write with a mouse, so bear with me here. All right. They don't have The abdominals, perhaps, they're a T7 or above, and if they're not too high of a cervical injury, they have accessory muscles, so they can inhale a pretty normal amount. It's just that they can't exhale the normal amount. So their residual volume is increased when you compare it to the normal person. Notice too, again, the slope. And when I mention the slope, we're talking about dynamic lung volumes. And if you remember, we had a forced vital capacity and an FEV1. How much air can I get out of the total amount? Okay, if this is the total amount that I can get out, my forced vital capacity, well, how much can I get out in 1 second compared to a normal person? And if we use this as the 0 point in the timer, and here's 1 second, we'll use this as the 0 point for the normal individual, and 1 second on the timer. The person with a normal FEV1 can get out about 75% of all the air that they're able to exhale, whereas somebody with a restricted disease, such as no abdominals, as in paraplegia, they're not going to be able to get out quite as much in that 1 second. Very similar to somebody with obstructive disease. So if you look back where we tried to differentiate between restrictive and obstructive diseases, the main difference between the two was the fact that patients with obstructive disease had these very low FEV1s. This is our tetra over here on the right hand side. And what do we see with the tetra? These total volumes are going to be much reduced. How much can I inhale? And certainly how much can I exhale? So vital capacity is going to be very reduced. Residual volume is going to be increased quite a bit. If we went from this line down to this line, we're looking at total lung volume, and you compare that with the normal person or the person with paraplegia, and a tetra's total lung volume is considerably lower than the other two folks. Okay, as far as the PT evaluation goes, you've seen this before. These same things would apply to the patient with spinal cord injury. What's their primary diagnosis? Well, in this case, it's the level of injury, and is it a complete spinal cord injury or is it an incomplete spinal cord injury? Certainly there's secondary and tertiary problems that are going to exist depending on when you see the patient and in what sort of setting you're going to see the patient in, what kind of medications are they on. A lot of these patients are on antispasmodics. Radiology would be important, especially if you're in the acute care setting and you have access to the radiologist's interpretation of x-rays of the spine, and you can visualize for yourself the level of the injury, the severity of the injury. Lab values, we would probably expect that if they're hypoventilating, then their arterial blood gases are probably going to be reduced. And so with that comes some issues regarding pH, CO2 levels. Think back or look back at your handout when we talked about acid-base balance when we talked about pulmonary patients in particular. So if this patient with spinal cord injury is indeed hypoventilating, then we're going to definitely see some changes in those lab values. Respiratory therapy, certainly in the acute care setting, it wouldn't be surprising that the patient is on some kind of mechanical ventilation. They're intubated perhaps. If the spinal cord injury is relatively low, then perhaps they're breathing spontaneously and they're able to maintain their blood gases. They don't need any mechanical ventilation. Just to review some things that we talked about previously, there's positive pressure ventilation and different modes. You have them listed in your handout that we went through, where basically air is being pushed in through a trach tube or nasopharyngeal tube or oropharyngeal tube. And so you're going to see these patients on these ventilators in both the ICU setting and in the step-down units or the ward. And you may even see those in home health when you're dealing with patients with a spinal cord injury in home health. They're on a mechanical ventilator. Usually, if somebody's going to be on mechanical ventilation for a long, long period of time, they have a trach tube in, and so as not to damage the vocal cords. But it's not a physiologic way of breathing. A more physiologic way is a negative pressure ventilation. And some examples that we threw out last spring was the iron lung. You're creating a negative pressure as you inhale because when the diaphragm descends, it creates a negative pressure, and in order to balance that pressure between your insides and the atmosphere outside, air rushes in. And so you've set up a negative pressure. Well, the iron lung can do the same thing. The person's head is sticking out at the end of this tube, and they can come out of these things for hygiene purposes and breathe on their own for a short period of time perhaps, but they get fatigued very easily, and so once their hygiene needs are taken care of, they go back into the iron lung. There are more portable kinds of things where you basically put a shell around a person's chest, or you put a belt around their abdomen. They call these things abdominal pneumobelts, where the pressure increases, air is inflated into the belt, which causes exhalation, pushes the diaphragm up, and then a negative pressure is created when the belt is deflated. If they're breathing spontaneously, you certainly would want to note what the FiO2 is, the percentage of or the fraction of inspired oxygen. Right now you're breathing room air, which is 21%, but sometimes folks are on supplemental oxygen because, again, of hypoventilation, and so they may be at 24%, 28%. How is it being administered? Is it a mask or nasal cannula? And then any therapies from an exercise standpoint, there's incentive spirometry where you would exercise the inspiratory muscles, exercise the diaphragm, exercise those accessory muscles. And there's little devices that people can use, put in their mouth and inhale and see how much pressure they can generate when they inhale. And there's also, we looked at pictures and examples of other kinds of incentive spirometry where you can not only incentivize inspiration, but incentivize exhalation too. So again, this is out of your textbook from the spring, and we used it to distinguish between patients with restrictive and obstructive diseases. Here's our spinal cord injured patient with a restricted disease. Their total lung volume is much reduced compared to the normal person. All right, and we'll just ignore what's going on here with obstructive. But keep in mind that if there is severe involvement of the abdominal muscles with spinal cord injury, then they will have a decreased FEV1, just like the obstructive patients demonstrate. But primarily it's a restrictive disease, but again with this little influence of obstructive, because just the way obstructive diseases are defined, the way the folks in the pulmonary world define obstructive diseases. Okay, patient evaluation includes obviously a patient interview, and so you want to get some idea. And again, these are identical to what you've seen previously in the spring. Patient interview, the mental status, prior lifestyle, cough. Do they have a productive cough or a non-productive cough? And then what are their vocational and recreational goals? Certainly if they're working age, they're going to want to get back to work, or perhaps they're in school, they want to get back to school. A lot of adaptations are going to have to take place with the person and the family. The home environment is going to have to change to accommodate the person with the spinal cord injury. There are definitely recreational goals out there, and there's all kinds of sports that folks with spinal cord injury can participate in, depending on their level of injury. So you can look up different websites or search for things related to spinal cord injury and sports activities. Lots and lots of good information out there, and lots of things that would help motivate your patient and help with the adjustment between what their prior lifestyle was and what their current and future lifestyle is going to be. The physical exam, exact same things. Observation includes things like general appearance. Do they have cyanosis or digital clubbing? Not likely in an acute care situation, the digital clubbing, because of the fact that this hasn't been, this hypoventilation hasn't been going on for a long period of time. But perhaps in a chronic situation over many years, the person does have digital clubbing because of this chronic hypoxia that causes this hypertrophy of the digits. The chest, do they have a trach tube in? Respiration, what's their rate and depth? Do they have a diaphragmatic pattern? When they take a deep breath, can you see scalenes and sternocleidomastoid come into play when they inhale deeply? Palpation, any areas of pain or tenderness that might exist. diaphragmatic excursion. You put your hand on their belly, have them take a deep breath in. Does the diaphragm descend, and does the abdominal contents protrude? Can you feel that protrusion with your hand on your on their belly? Auscultation. We talked about auscultation. Do they have adventitious sounds, added sounds, things like rales, small airway, fluid accumulation versus rhonchi or wheezes, large airway, fluid accumulation. And then joint mobility, rib cage mobility. Certainly if their inspiratory muscles are involved and expiratory muscles are involved, then compliance of the thorax gets compromised. The thorax gets stiffer and stiffer. Trunk. Do they have any trunk? That again depends on the level of the spinal cord injury. But that lateral bending, that rotation, that flexion extension of the trunk all has an impact on the mobility of the rib cage. And then upper extremities, again, what's the level of the injury? How high up is the injury? Do they have full upper extremity range of motion, full shoulder range of motion? That would certainly impact on the compliance or the mobility of the thorax itself. Okay, so treatment interventions, we mentioned postural drainage or just simple positioning in the most optimal way of getting the large airways in the most vertical position possible. We talked about percussion, and perhaps it's contraindicated in the acute care setting. Vibration, and if you're in the acute care setting, especially in the ICU setting, it's possible that you'll be doing some suctioning. You're going to need on-the-job training to do that from the respiratory folks. But once you feel competent and they feel comfortable in your ability to suction safely, then that frees them up a little bit and doesn't demand as much attention, and it, you know, is a nice team approach when you're working in the ICU with the folks in respiratory care. And they can help you with things like sitting on the side of the bed, bed mobility. You and the RT and the nurses are all working together as a team. Assisted cough. We want to help eliminate those secretions. And so do you as a therapist assist in that cough? And you can do that by simply compressing the thorax, compressing the abdominal contents. So you see examples of both of those here, where two therapists are working together on this patient in one instance, and one therapist is working on the patient in another instance. But that's basically an assisted cough. So a decrease in hypoventilation. All the things that we can do to decrease hypoventilation includes incentive spirometry, chest wall mobilization, which you just saw pictures of, and then resistance and endurance training has to be consistent with the level of the injury, obviously, but those are all things that can be done, and certainly if the patient has goals along those lines, you want to be working in that direction. And any kind of physical activity, whether it's resistance or endurance or a combination, is going to help with their ventilatory capacity. Okay, so that's pretty much it for the pulmonary system. Again, all review. Now for the cardiovascular system. Again, a picture you should not be surprised by. The heart, the lungs, arteries, veins, etc., etc. Cardiovascular disease after spinal cord injury. So what's the biggest cause of death for survivors greater than 30 years and those older than 60? Well, it's atherosclerosis or coronary artery disease. And I encourage you to go back and look at your clinical pathology notes when we discussed the pathology of atherosclerosis. But it's heart attacks that are the biggest cause of death. These folks also suffer from deep vein thrombosis. They have decreased venous return, so they have venous pooling. With venous pooling, you have slow motion blood flow through the vascular system, and that is a risk factor for folks with spinal cord injury. Okay, we need to talk about the sympathetic nervous system because what you see in the handout is something referred to as autonomic dysreflexia or hyperreflexia, and we'll talk a little bit later about cardiac output, venous return. We've already touched on some of those things, but a lot of these things have to do with the fact that some of these patients have very compromised sympathetic nervous systems. And you know the influence of the sympathetic nervous system on cardiac output and on venous return. So there's a massive imbalance reflex sympathetic discharge, and we see this in patients that have the injury at or above T6. It's a medical emergency, and we'll elaborate on this in more detail in a few minutes. Typically not seen in the first month post-injury, usually present by 6 months post. 92% of people with a spinal cord injury at T6 or above exhibit their first episode by 1 year. So just a quick review of the autonomic nervous system, and we're not going to worry too much about parasympathetic, all right, but we certainly are going to look at the sympathetic nervous system. And what you need to take away from this, the most important thing, is where do we start to see sympathetic nervous system exit the spinal cord? At what spinal level do we see things exit, and then where does it stop? Well, this happens to be T1 up here. And this is L2, L3, and so anybody with a spinal cord injury above T1 has essentially no sympathetic nervous system. So give somebody a cervical injury, tetraplegia, complete tetraplegia, no sympathetic nervous system. So very little increase in cardiac output when they exercise. Very little dilation of the bronchi when they exercise. And then there's some other things here that a few of them we'll talk about in a bit. All right. But again, if I'm counting right, 1, 2, 3, 4, 5, 6, somebody with an injury at this level, okay, or above, is going to have this autonomic dysreflexia. And so this is the picture that you have in your handout. And so we're looking at that patient with that T6 injury, okay, and nothing gets past that injury, okay. Well, let's provide a stimulus that's going to cause a sympathetic response. And one of the more common things that brings about this autonomic dysreflexia is a full bladder. All right. And so when you have a full bladder, you're made aware of that, and you go to the bathroom and you empty the bladder. Well, the person with a spinal cord injury doesn't have that awareness, okay? And so these afferent impulses that notify the cortex that the bladder's full don't make it to the cortex. And they do spill over and cause this widespread vasoconstriction. So these pain signals, essentially, is what they are. And if you want to know the track that run in the lateral spinal thalamic tract, your pain and temperature. And so anything that's irritable, and you've got other afferent stimuli shown in the picture, the bowel, it could be anything, and we'll list a few of those on the next page. But again, we get this sympathetic response, and what that does is causes this widespread vasoconstriction. All right. Well, widespread vasoconstriction occurs everywhere. All right. And so that's basically picked up by the baroreceptors in the arch of the aorta and the bifurcation of the carotid, common carotid, into internal and external. So we're sensing this hypertension, and you can follow the numbers along here, all right? But what would normally happen with hypertension is those signals are fed to the vasomotor center in the pons and the medulla, and we would get a slowing of the heart rate, okay? And we would get descending inhibitory signals that would essentially counteract the vasoconstriction. So these inhibitory signals would cause vasodilation and get blood pressure back to normal. But the inhibitory signals are blocked at the level of the spinal cord injury. And so we develop this hypertensive response, and as I mentioned earlier, it's a medical emergency. So, what are some of these afferent stimuli? Bladder distension, bowel obstruction. It could be a wound in the skin that the patient doesn't sense below the level of the injury. I had a patient a long time ago tell me that he, without knowing it, burned his leg because he ran his wheelchair underneath the sink and his leg was against the hot water pipe. And so he didn't know it until he looked down and saw it. Sexual activity can bring about these episodes. Deep vein thromboses, broken bones, tight clothing, tight shoes, extreme temperatures, both hot or cold. So, how do they present themselves? What are the signs and symptoms? A sudden increase in blood pressure. Along with that comes a severe pounding headache. They get some bradycardia, profuse sweating above the level of the lesion, flushed skin above the level of the lesion, piloerection or goosebumps above the level of the lesion, blurred vision, nasal congestion, anxiety, the jitters, chest tightness, atrial fibrillation, shortness of breath. I want to show you this YouTube video. You have the link in your handout. I'll get my arrow back here. There we go.
Hey everyone, today I'm coming at you with an educational video about autonomic dysreflexia. Autonomic dysreflexia affects spinal cord injured people with a T6 or above injury. Autonomic dysreflexia is potentially a life-threatening condition if not handled properly. Autonomic dysreflexia occurs when something below the level of your injury is bothering you. It could be anything from your pants are tied too tight, you got your underwear too tight, you got a cut on your leg, you injured yourself somewhere and you don't know. It could even occur if you get spill water on you, like the cold sends a quick shock up your body, and it's basically your new warning system of, hey, something's not right. All right, it could be anything. It could be internal things, and 9 times out of 10, it's a full bladder. That is how I know that I have to use the bathroom when I get symptoms of autonomic dysreflexia. And then I just empty my bladder and I'm good. So what occurs is that you get onset symptoms that can be anything from feeling really cold or really hot. You really lose your regulation, your body temperature regulation, which most of us with a cervical injury don't have to begin with, because that's controlled by your autonomic nervous system. And then your blood pressure begins to rise because your body's sending signals up your spinal cord, and your spinal cord has glial matter, which is dead nerve cells in your spinal cord that are blocking the signal from going either way. So then it can't reach your brain and say, hey Matt, you probably got to pee, or you broke your leg, or whatever the case may be. So then it bypasses your brain and it goes to your heart. And your heart goes crazy into a fight or flight mode, and it starts beating rapidly and raising your blood pressure. Now, it can be controlled with a simple checklist of like, all right, let's check my legs, let's check my feet. All right, are these shoes tied too tight? My pants tied too tight? Did I bruise myself when I did that transfer or whatever it is? But then your number one thing after that should be emptying your bladder, because 9 times out of 10, it is your bladder, and it is so easily controlled. Now, when symptoms occur, you don't want to be lying down. You want to be elevated, either in a sitting position or a standing position, because you don't want that blood pressure to rise too quickly. And when you're lying flat or with your head facing in an inverted position, your legs up, all the blood's already rushing to your head, so it makes it really easy for your heart to pump that blood into your brain. And what can happen when you have really, really, really high blood pressure is you can have a stroke. You have blood vessels in your brain and arteries that go up there, and the walls can get weakened because of the immense pressure. And then you bleed in your brain internally, and you have a stroke, or you could die. So you should always have a checklist. And if you see someone out in public with a spinal cord injury, try to use the bathroom. Don't be a dick and take up the big stall or whatever, because it's like hard for us to do things. And somebody could be waiting there, having to pee with their head pounding, and they're just like in agony, and it could be life-threatening. So people should also be aware of that. Caretakers, family, friends, they should be aware of it. It also causes me to clench my jaw. I get goosebumps. Sometimes I sweat. My eyes go crazy, like my pupils dilate and they shake, and I get like these prickly feelings in my face and my eyes. It's really strange stuff, what your body can do. Just be aware of it. Have a plan. Know what you're experiencing. And if you have any questions about autonomic dysreflexia or anything else, please let me know. Leave it in the comments below, or email me on the YouTube channel, and I'll be happy to answer your questions. Suggest me new videos, whatever you want. Alright? So, I'll be coming at you with some more videos soon. See you later!
Alright, bear with me here. There we go. Okay. So, he summed it up pretty well, I think. I should just let him do this lecture. He mentioned some of the things that obviously you need to do, what the patient themselves needs to do. They need to be, first of all, educated on this. Again, it's a medical emergency. Where is the noxious stimulus? He mentioned looking, having a checklist. He mentioned to sit upright, do not lie down, because that's just going to increase the blood pressure in your head and make matters worse. Because it's a medical emergency, then folks in EMS, or once you get this person to an emergency room, calcium channel blockers, the nitrates, all things that are going to reduce the vasoconstriction will be employed to alleviate this hypertensive response. If you're with the patient, then obviously you want to continue to monitor their vital signs, blood pressure in particular, for the long term. Again, patient education is a key, and a wallet card perhaps, identifying the person, or a medic alert bracelet that indicates that the person has frequent bouts of autonomic dysreflexia. So what are the consequences? He mentioned a stroke, and there's various ways of having a stroke, but intracranial hemorrhage is one of those. Certainly we can do serious damage to the retina with high blood pressure, seizures, perhaps death. Here's a picture that I showed you back in our neurology discussion of in clinical pathology, golly, a year ago, huh? And so you see an area of the brain that's basically full of blood. And I'm not going to switch back to my pen because I got another video to show here in a second. Okay? So we certainly don't want anything like that to happen, patient having a stroke. Okay, prescription guidelines for cardiorespiratory fitness. I do a full lecture, 2-hour lecture on exercise for the disabled population. And I would be happy to send that to you if you're interested. Actually, I think I will attach that to your integrities in this course. I'll have to see if I can find that and get it to you. But in many cases, patients have to rely on arm exercise, and so there's all kinds of wheelchair sports out there. They have a loss of the sympathetic nervous system, and again, that varies depending on the level of the spinal cord injury. Certainly, folks with tetraplegia, complete tetraplegia, are not going to have any sympathetic nervous system, and that's going to have an impact on what kind of exercises they can do. How much ventilatory capacity do they have? How much cardiac output capacity do they have? And so, again, you need to just think about sort of the principles of cardiopulmonary fitness, the frequency of the exercise, the intensity of the exercise, the type of the exercise, dynamic, rhythmic, things that we talked about in cardiac rehab. All these same things would apply to patients with a spinal cord injury. And then time, how much time do they spend doing these activities? And one of the confounding factors is if we have a reliance on arm exercise and we're doing wheelchair sports, racing marathons in a wheelchair, that puts a lot of overuse on the shoulder and the elbow and the wrist. And that's going to make it difficult, if that becomes an overuse syndrome, going to make it very difficult for that patient to do any kind of ADLs, let alone doing cardiorespiratory fitness kinds of activities. So, you have another website in your handout. I like this because it really is kind of an inspiring sort of video. And if the quality doesn't come out on this integrity, you can always open it on your own computer directly through the YouTube website.
You know, all my life, I wanted to be able to do one thing better than anybody else and was very unsuccessful. And then I had my accident and I thought, you know, maybe I can be the best quadriplegic on a respirator that ever lived. And then, wouldn't you know it, Christopher Reeve goes out and breaks his neck. And I'm in competition with Superman. I worry a little bit about how I'm going to be perceived by others when, especially when I go out in public. I like to wear a ball hat almost everywhere I go because my head's very sensitive, but Joanne will hardly ever let me do it. She says it makes me look too conspicuous. And I certainly wouldn't want to look conspicuous. The other day, we went to this elementary school, and as we were leaving, we were going through the playground, and on our way to the parking lot, a group of 5-year-olds were having recess, and they saw me in this wheelchair, and they just came and surrounded me. 5-year-olds are the greatest. They are so open. I guess we could all learn a big lesson from little children about how to react to people that have a little bit of a physical problem. But they surrounded me and they were saying, "Hey, mister, what happened to you? What's that hose hanging out of your neck? And how does this chair work? And what is this all about?" And there was this little kid that was kind of hanging around the edge, and I knew that he wanted to ask me something, and he just couldn't quite get his courage up, and finally he got up real close to me, and he looked me right in the eyes, and he said, "Hey, mister, what happened to your face?" And I thought, my face? I thought it was the only part of me that even halfway worked. And I tried to run over the kid. You know, even though my health is very good, Joanne still insists on taking me to the doctor every once in a while for a checkup. And so we go, and they do blood work, and the nurse gets the needle ready to take my blood, and I always ask her, "Is this going to hurt?" She pats me on the arm and says, "Well, it'll probably sting just a little bit." Well, as they get done examining me, and they usually tell Joanne, "Well, Mrs. Rushton, bring him back in 6 months or 6,000 miles, whichever comes first." A while back, I was getting into my modified van, and there's an open space by the driver's seat so that I can sit by Joanne. That's a whole other story. But as I was getting into the van, this one day, my ring finger on my left hand got caught on that seat. And as I was going in, it was bent all the way back to my wrist. And as I watched it, I said to myself, "Boy, I'll bet that hurts." And sure enough, it got all black and blue, and it got all swollen up, and so Joanne says, we got to go to the doctor. And we went to the doctor, and they took an x-ray, and we're sitting in one of those little rooms they stick you in, and the doctor came in with the x-rays in his hand, and he didn't really look at me that closely, and he said, well, Mr. Rushton, you got a fractured finger, and we're going to have to immobilize that finger. And I thought, my golly, where did you go to medical school? You've heard of child abuse and spousal abuse, and I've invented a new category that I call quad abuse. Let me give you some examples. Every morning, my wife and another woman get me ready for the day. It takes about an hour and a half. Then as they work over me, they talk, as women do. I've heard things that no man ever ought to have to hear. And then they get to the point where we have to decide what I'm going to wear for the day. And Joanne says, Jack, what would you like to wear? And I tell her, and then you know what she does? She puts on me whatever she wants. And I can't do anything about it. And the bad thing is that everything has to match. My oldest son, Mike, says, Dad, when you get ready to go out the door, you look like you're ready for preschool. And you know, before this accident, I used to get up in the morning and put on a pair of Levi's and a t-shirt, or I'd wear a suit and a tie, but I've discovered now that I wear outfits. I was on a talk radio show a couple of years after the accident, and the moderator said, Jack, what brings you the most peace? To believe that God brought the wave that broke your neck, or to believe that it was just an accident? And I said, you know, I probably haven't spent 5 minutes thinking about that question. I simply do not know why these things happen, and it matters little to me. I don't know why people get cancer and little children die, and all of the tragedies, man's inhumanity to man on this earth. I don't know why a lot of these things happen, but I know only one thing for sure. There is a loving, kind God, a heavenly Father that cares about us as individuals. And with his help and his power, we can cope with any situation that life may bring to us. We can overcome our challenges and our problems with his help. And I want you to know from the bottom of my heart that the burden of paralysis literally has been taken from my shoulders, that I do not even feel it. And I'm so grateful for that. And this is the one thing I know. I thank you all so much for coming tonight.
Okay, so that's all I have. I'm gonna stop this right now, and if you have questions, you know how to get a hold of me. Hopefully I'll be able to answer them. Y'all have a great semester, and looking forward to seeing you at graduation come summer of 17. Bye now.